Hello, everyone. Welcome to another virtual morning report. Really excited to co-discuss with Mark today. Mark and I became hospitalists at the same time last year, about a year ago, and we send each other cases all the time. So I'm really excited to co-discuss with him.
All right. So, is it okay if I start?
Yeah,
Yeah,
please.
totally.
Do you want
Awesome.
to introduce yourself as well, Jeffrey?
Yes, thank you. So I'm Jeffrey Shen. I'm one of the Duke rheumatology attendings. I'm a new academy member here. I've been interested in clinical problem solving for a really long time and really excited to share this case and have Yosef and Mark take a crack at it. Okay.
Absolutely. Excited.
All right, so for this first aliquot, it's going to be their history, and this is going to be a pretty extensive aliquot. So we're going to start with arthritis and abdominal pain. Then eventually she's going to go into a coma. So this is a 29-year-old woman. She has a history of seropositive rheumatoid arthritis. She was in her usual state of health until 1 month ago. And at that time, she said that like there was some mold in her apartment around that time, and she had to get the cleaners, like the cleaning company over there. And so like the day, 1 or 2 days after that, she started developing a cough and then started getting like diffuse joint pain and stiffness. Um, Initially thought it was, maybe just a reaction to that, but then she realized it could have been a rheumatoid arthritis flare. So she called her rheumatologist and was started on a prednisone taper from 20 milligrams. And also her methotrexate, which she had been taking at 15 milligrams. The dose of that was increased from 15 milligrams weekly to 25 milligrams weekly. And she kept continued on her folic acid 1 milligrams daily, which is what she usually uses to prevent side effects from methotrexate. So her rheumatologist essentially tried to treat her for a RA flare, and then 1 week later, unfortunately, she developed new symptoms of nausea, what she described as severe epigastric abdominal pain, fatigue and malaise. She said like it felt like she like had caught a flu. And, initially thought maybe it was just a flu or COVID, but she tested negative. Again, called her rheumatologist, and they were concerned like, oh, could this be, because we increased the dose of methotrexate? So the decision was made to stop the methotrexate, and he told her to increase the folic acid to 2 milligrams daily. But according to the phone call notes, it sounds like she may have been actually taking about 8 to 9 pills of folic acid daily, which was necessary for her to actually get some relief of her symptoms. So she started, taking that, and it seems like maybe things got a little bit better. But then 7 days prior to her presentation here, she again reported having symptoms of a viral illness with symptoms of malaise. And again, her joints were aching, her muscles were aching. She had some subjective fevers, nausea, and dizziness. And at that time, she again didn't really know what was going on. Was it like a virus again, or was it from her RA flaring, or was it from methotrexate? And she was her PCP, her and the rheumatologist were trying to figure out the next steps to do. It was unclear if anything was actually changed. It doesn't look like any medications were changed. And they were trying to do some investigation with laboratory workup. So that was 1 week prior. And now, 3 days prior to presentation, so 4 days after having that viral illness thing come back, she reported severe abdominal pain again, and she described it as diffuse. Was hard to localize it. Also, at that time, went to urgent care, told them that she hadn't had a bowel movement in several days, so they thought it was probably constipation induced and gave her some laxatives. And then now we're on the day of presentation. So she was non-responsive at home, and her husband seemed like he came back from work and found her non-responsive, called 911. And then when EMT arrived, based off of their notes, it seemed like they were unable to wake her up, and so they had to intubate her in the field. Based off of their description, they noticed that she had some blood-tinged respiratory secretions. They were unsure if she had seized or not. By the time her husband came home, he didn't notice anything. But because they were unsure, she was empirically given IV lorazepam in the field as well. So they moved her from the home to the local ER, who at that time started her on IV fluids, broad spectrum antibiotics, covering for most normal bacteria, for pneumonia, and as well as for infectious meningitis, as well as starting IV pulse dose steroids of 1 gram IV solumedrol for possible rheumatoid arthritis related meningitis. And because of how complicated the situation was, she was transferred from the ER to an academic medical center for evaluation by multiple subspecialty teams. And that's the end of the first aliquot.
Yeah, Jeffrey, what an aliquot, such rich in information. Mark, before we dig deep into the presentation, I know your information on rheumatoid arthritis is very broad. Do you want to just start commenting on the diagnosis itself, and then I can talk about immune suppression and then the presentation?
Totally, totally. And Youssef, when you told me that Jeffrey was presenting a case, I knew it was going to be tough, but this is next level. So I'm excited for this. Yeah, no, I could talk a little bit about rheumatoid arthritis and maybe how that influences like the foreground. Um, at first, I was a little struck by the age of the patient. I'll say, at least from like an internal medicine hospitalist perspective, and I know Jeffrey sees the whole spectrum of patients with like rheumatological disease, but I typically think of like rheumatoid arthritis and more um, middle age patients. I think that is not a rule, but it just struck me that the patient was 29 years old, so I thought that was interesting. And then with any like disease, like rheumatological diseases or really any disease in general, I always am curious of how the diagnosis was made. And I think Jeffrey said that this patient has seropositive rheumatoid arthritis, so I assume they have a positive rheumatoid factor in CCP, but maybe they just have a positive rheumatoid factor and they have arthritis, and then maybe we actually don't have the correct diagnosis. So I'd be very curious. So if the patient had a positive CCP, which is very specific for rheumatoid arthritis, I'd feel definitely very confident with the diagnosis. And also, again, I would want to know the clinical features too. Do the clinical features match rheumatoid arthritis? Like, does this patient have, small joint polyarthritis, which would be like the most common, clinical manifestation of rheumatoid arthritis? So I just kind of want to know about how that diagnosis was made and how long they've had that for. The interesting thing about seropositive rheumatoid arthritis as opposed to seronegative rheumatoid arthritis, I think this is important for this patient's presentation, is that these patients have a higher rate of extra-articular disease as opposed to patients with seronegative arthritis. So I think especially important for this patient that, the hospital was invoking possible RA meningitis. There are some CNS manifestations of rheumatoid arthritis, like CNS vasculitis and again meningitis. So the seropositivity maybe points us a little could increase the risk of these extra-articular manifestations. And then this patient was on pretty typical medications for rheumatoid arthritis, methotrexate, prednisone for a possible flare. The one thing to keep in mind, I guess, with the methotrexate is that methotrexate does have, side effects. And the one to keep in mind for this patient is it can cause like pulmonary toxicity, whether that being like acute pneumonitis or even like ILD. And I know this patient had some blood tinged sputum that we'll learn a little more about with our like, chest imaging and some labs, but I'm just kind of keeping that in mind. Not that that would explain the whole story, but kind of just thinking about how these, medications can influence the foreground. And that's kind of it. I would say in terms of, I know this patient's having a lot of, GI symptoms, and I'm trying to think like if I'm just solely thinking about how like RA can affect the GI tract, I would say that's like probably a less common organ that rheumatoid arthritis affects. So, like rheumatoid arthritis can definitely cause serositis, right? So most commonly that being like pericardial effusions, pleural effusions. I would say like ascites and like peritoneal inflammation is probably less common. Of a like serositis manifestation, but the patient is on prednisone, which increases the risk of like ulcers and other GI side effects. But just solely from an RA perspective, I definitely think GI manifestations are a little less likely. But yeah, Yusuf, that's kind of how I'm kind of thinking about. I want to know how this diagnosis was made, how long they've had it for, and then just keeping in mind that the seropositivity, if the patient truly has like a positive CCP, that could increase the risk for some of these extra articular manifestations. But yeah, what do you think?
Yeah, I love that, Mark. Your knowledge of rheumatoid arthritis is so broad, and I'm so impressed. Uh, about this presentation, it sounds like this young patient initially presented with abdominal pain, some joint pain, and then now progressed to having like neurologic symptoms. She was found unresponsive. And I think to just start creating buckets in anybody with autoimmune disease, you want to think of complications of the disease itself. So if this is RA, could they have like vasculitis, like Mark alluded to, which could be in the abdomen or in the CNS? Although the rheumatoid vasculitis is typically an older diagnosis because with current treatments, we don't see it as much. It's usually a symptom of not getting treated for a long time. So the first bucket is complication of disease. The second bucket is association with other autoimmune diseases. So if you have rheumatoid arthritis, you might develop lupus, also called like lupus. And you could have like another autoimmune disease because your genetic predisposition that predisposed you to get the rheumatoid arthritis can get you to another autoimmune disease. The third bucket is a complication of the immune suppression. So in this case, we hear about steroids and methotrexate, and it's very important to characterize the type of immune suppression whenever you say somebody immune compromised. So instead of just saying immune compromised, here I would say they're on methotrexate, which mostly affects the T cell arm of the immune state. So that T cells usually protect against intracellular organisms and viruses. So for example, if you think about it, why do patients with DKA get mucor, while patients with HIV, we think of CMV colitis? And we don't think of CMV colitis in patients with DKA because of the different arms of immunity. Because in DKA, the neutrophils are dysfunctional, while with an HIV, the T cells are dysfunctional. So in this case, the methotrexate would affect the T cell, while the prednisone can affect both the T cell and the neutrophils. And depending on the dose, you can decide on the degree of immune suppression. But in this case, I would at least say moderately to severely immune compromised individual. So that puts them at risk for infections. And then lastly, the one thing we forget as well is that immune compromise also causes you to be susceptible to malignancies. Malignancies, your immune cells are also good at attacking malignancies. So you're also at risk for malignancies whenever you're immune compromised for a long time. Now, we spoke a lot. I think for this patient, I think we want to make sure what's going on in the abdomen, and I think we want to see what's going in the CNS. We often think about the missed mnemonic and for the CNS, and we want to make sure there's nothing structural. And if there's nothing structural, we would be running towards the LP, but I'm not going to say more. I think we can wait for more information.
Awesome, awesome. Wow, you guys have already discussed a lot of things, and I'm excited to give you a little bit more. So, unfortunately, because she's in a coma, I can't really get any history from her. So, some of this history is going to be from what we can see in the chart, and then a little bit from talking with her husband. So, this next aliquot is going to be her past histories, and it's also going to be her physical exam. So she does have a long-standing history of seropositive rheumatoid arthritis, diagnosed when she was about 22. It is a little bit young, but with rheumatoid arthritis, it actually does overlap with juvenile idiopathic arthritis, and there are forms in which you're seropositive. So I don't really use age as a great marker anymore as a way to differentiate whether rheumatoid arthritis is true or not. But she, at that time, was noted to have a positive rheumatoid factor and a negative CCP. And her manifestations based off of their notes were that she had documented synovitis in multiple joints. Her only other past medical history is significant for some anxiety. And for medications, the only medications that she takes is sertraline for the anxiety and prednisone and methotrexate for the rheumatoid arthritis. She doesn't have any history of surgeries. And family history is notable for lupus in her maternal grandfather. And her aunt has a diagnosis of sarcoidosis and also has colon cancer. It looked like on the report, she couldn't remember, but it looked like the report that the age that she got colon cancer was something like over 50. And then on social history, when talking with her husband, she is an administrative assistant at a law firm. They live in an urban area. She denies or he denies that she had any smoking. She says that sometimes in social occasions, they will drink alcohol and also smoke marijuana, but no other recreational drugs. She is monogamous with her husband as far as we were able to get on both his history and both on exam, but as you can say, it's quite limited to know that for sure since she's in a coma. And then she also has a pet turtle. They have a pet turtle at home. No other pets. No travel history in the past year or two. No unusual exposures. He does say that the other things is that they have been trying over the past maybe year or so to kind of go more natural, fixing with the anti-inflammatory diet, and trying to start some natural remedies to help decrease inflammation from rheumatoid arthritis. And then on her physical exam, start with her vital signs. She is afebrile with maybe a low-grade fever. Her temperature is 100.0 initially at our institution. Blood pressure is 104/74. Heart rate's 106. And then she's on the vent for the respiratory vital signs. In general, she is intubated and sedated. She is not really having much spontaneous movement, maybe minimal spontaneous movement. Um, on HENT exams, kind of hard to attribute we find there to the intubation itself or what's before, but it's noted that she has some dry blood on her lips. She does also have some like lacerations on her lips and tongue. We were unable to get a history from like EMT of whether that was like there before or after. And she does seem to have some colitis and oral ulcers in her mouth, like on her tongue and soft palate, that maybe also had some blood. On neck exam, she had no lymphadenopathy. Cardiovascular exam, she was tachycardic. No murmurs were heard. Pulmonary exam, she had coarse mechanical breath sounds on the ventilator. On an abdominal exam, she had some hypoactive bowel sounds. There was no rash. And MSK exam, she did seem to have possibly synovitis of her second and third MCPs in her wrists and her ankles, just based off of the edema there and the localization of the edema to the joints. But obviously, because she's in a not in a mental state where she can tell us if she's having pain there. And then the only other addition in the neuro exam, so she is sedated with minimal spontaneous movement, but she doesn't have any clonus, no Babinski, and she does have 3+ patellar reflexes. And that's the end of the second aliquot.
Youssef, you want me to go first?
Uh, sure.
Cool. I can talk a little more about the background, and then maybe you could start with the physical exam, and then I could also talk about it as well.
Sounds good.
Cool. So yeah, Jeffrey, thanks for giving us some of that past medical history. I kind of talked about just wanting to know how this diagnosis was made, and it seems like Jeffrey, do you have? And I know we have the exam now, but when you were mentioning that she had like synovitis, like where did she have synovitis classically? Like when it was first diagnosed, and like how many joints was it in?
Yeah, it seemed like on the original notes it was polyarticular. She had it in MCPs, PIPs, wrists, ankles, knees. There may have been more, but it was very diffuse on initial diagnosis.
Okay. And bilateral as well?
Yes, it was symmetric.
Okay, cool. So yeah, the clinical manifestations are rather classic for rheumatoid arthritis, like a bilateral symmetric polyarthritis. So I feel pretty good about that. The patient does have a positive rheumatoid factor and a negative CCP. A negative CCP definitely does not rule out rheumatoid arthritis. I'll just mention that a positive rheumatoid factor does not equal rheumatoid arthritis. It's a very non-specific, marker. It can be seen in, patients with Sjogren's, cryoglobulinemia, mixed connective tissue disease. It's a bunch of rheumatic diseases that can be present. And then also, importantly, non-rheumatic diseases as well. Classically, and I've seen cases in real life and then also on VMR that endocarditis related glomerulonephritis is a classic cause of positive rheumatoid factor. So keep in mind non-RA related rheumatic diseases, infections, and also malignancies. It's very, very non-specific. But like I said, the clinical manifestations fit pretty well for rheumatoid arthritis. So like I said, I feel good about that. And then we kind of already talked about the medications, the prednisone, the methotrexate. I'll just mention the turtles because my wife's an ID doctor, so I have to bring up the turtles. The thing that I think most of us think about with turtles is salmonella. So turtles definitely can transmit salmonella, and then this patient being immunosuppressed, they're definitely at risk of invasive salmonella. And some interesting things about salmonella, and I don't exactly know why. Classically it causes a GI syndrome, which this patient has a GI syndrome. But it also can cause aortitis, and it's one of the infectious causes of aortitis. And I've actually seen a case in real life of this. So, and when you have aortic inflammation, that definitely can extend to other, great vessels and can cause some, I would say CNS manifestations would be very uncommon. But like I said, if you have inflammation in your aorta, that definitely can extend vertically. So I'm kind of keeping that in the back of my mind, especially with these GI symptoms. But turtles are really nice. I like them more than cats, so I'll be nice to the turtle. Um, but that's kind of my thoughts on the background. Yusuf, I don't have any really many new thoughts about the rheumatoid arthritis. I'm glad that it sounds like it's a pretty classic clinical syndrome for it. What do you think about the exam?
Uh, the thing that caught my attention was the laceration on the lips and the tongue, some cheilitis, and the oral ulcers. I think usually when I hear of laceration on the tongue, I think of like a seizure. It has like a positive likelihood predictive ratio. It could be also an injury from like intubation, for example. But however, I don't expect like cheilitis or oral ulcers, and it would be an interesting point to discuss, like what is the differential of oral ulcers, because we see those not infrequently. And I think you think of infectious etiologies include HSV, so herpes virus, and that can present in oral ulcers, and VZV and other like viruses can cause that as well, but most commonly is HSV. There are some like autoinflammatory causes like Behçet's, for example, or abscess ulcers, which are very common. And then the third thing I think of is like toxicity from the medications. Like, could this be like methotrexate induced mucositis? And if the patient is taking a supplement, for example, that could cause a CYP inhibition, for example, causing increase in the levels of the medication over the other. So that's what I'm thinking of. And then for the 3+ patellar reflexes, I don't think I'm necessarily giving it too much attention at this point. And what do you think, Mark?
Yeah, no, I love that comment on the oral ulcers. Like if we, I would say most commonly, especially if the patient, like if the husband's like, this patient, she has never had oral ulcers before, and maybe this is just a manifestation of a traumatic intubation. Actually, before I talk about it, Jeffrey, do you know if that was like present before, or if this was obviously just from intubation or something like that?
We weren't able to figure it out based off of EMT. Nobody could give us any more information.
Gotcha. Okay. So yeah, but maybe we'll just assume you said that is like a new manifestation. And then just thinking of like what diseases can cause like oral ulcers and CNS manifestations. Like you mentioned, Behçet's syndrome, which is very interesting, which definitely can cause arthritis, and then also has very commonly causes GI manifestations. I think I learned that like in Japan, like Behçet's is more common than IBD and can completely mimic IBD and cause like ileitis, and it also is a variable vessel vasculitis, just like rheumatoid arthritis. So you can get like mesenteric vasculitis that can definitely cause some GI manifestations. So that's very interesting, and we'll definitely want to get more history if we can from the husband to see if this has happened before, and then also if she has genital ulcers as well, which would kind of point us towards that. But yeah, then I'm kind of just Yusuf, I forgot. Did you mention about the hypoactive bowel sounds? Did you talk?
Oh no, I did not.
Yeah, gotcha. Yeah, no, I mean, this patient has had a GI syndrome, which we mentioned, and I think I love our VIPO mnemonic. And for everyone that's like new to the CP solvers, we have this VIPO mnemonic for no missed causes of abdominal pain, that being like vascular, infectious, perforation, and obstruction. So in someone like this, I would definitely, especially given how sick she is, she's probably going to get, cross-sectional imaging, probably of her whole entire, head, given the mental status, her chest, given some bloody secretions possibly, and then given this hypoactive bowel sounds, and also some GI symptoms, probably her abdomen and pelvis as well. So we want to rule out any of those scary things. And then, would definitely want to keep an eye on the vessels. Like I said, we mentioned like vasculitis a few times. So definitely want to keep an eye on the vessels. If there's any vessel inflammation, that could be causing ischemia, which can increase your risk for ileus perforation. So that's kind of where that I kind of definitely want some stat imaging for this like really, really sick young patient. Yeah, Yusuf, anything else on the exam?
Nothing to add. Like you said, like we're headed towards brain imaging, it has to be like CT then MRI at least, and then you want to see like the electrolyte panel, the kidney function, probably see if you can get like a methotrexate level, and then depending on those, you will have to consider like a lumbar puncture plus minus.
For sure. Yeah, I would definitely CT, and there's nothing crazy on the CT head in terms of like a space occupying lesion that would make a lumbar puncture unsafe. I would definitely get the lumbar puncture. And I definitely think that a patient like this, like a CT head is not enough, right? Like I think it's just to rule out the scary like intracranial bleed or humongous like ischemic stroke, but I definitely would want some vessel imaging and probably an MRI, even if the CT head is negative. Because remember, Dr. Berkowitz, Aaron Berkowitz, like taught us too that a thing to consider on the differential of a comatose patient is a bit basilar artery occlusion, so that might not pop up on a CT head, and you need CT of the vessel. So yeah, this is a really interesting case, really sick patient.
All right. Yeah, I love all the thoughts that you guys have said. Very, very broad and comprehensive. So this next alcohol is just going to be the initial labs when she gets admitted. Again, she already got 1 gram of IV solute measurable started at the outside hospital, as well as some broad spectrum antibiotics and fluids. So her CBC showed a leukocytosis of 15,000 with 83% neutrophils. Her H&H was 8.7 and 25, so she was anemic with an MCV of 74, so microcytic. Platelets were 205, which were normal. And then as far as her BMP, her sodium was 136, potassium was low at 3.3, chloride was normal at 103, bicarb was low at 15, BUN was slightly elevated at 26, creatinine was elevated at 1.9, glucose was elevated at 266, calcium and magnesium were both actually within normal limits. AST on her CMP was elevated to 128. ALT was elevated to 162. Alk Phos was elevated to 114. Her protein was 6.1 and albumin was low at 2.9. Her CK was elevated at 1,286. Uh, Urinalysis studies were notable for a specific gravity of 1.012, pH of 5.1, 2 plus protein, 2 plus glucose, 1 plus ketones, and negative for blood. And then her urine drug screen was positive for marijuana and benzos. Sorry, for the urinalysis also was not only negative for blood, but also for white blood cells, red blood cells, nitrites, leukocyte esterase. And her CSF studies, so a CT had been done to rule out a mass. So CSF was performed and it showed normal results for white blood count, red blood cell count, protein, and glucose. So they're all normal. Their viral panel of PCR was done on CSF, which was negative. Cultures that were obtained were negative. AFB and fungal cultures were obtained, and those were negative but pending, and cryptoantigen was negative.
Wow. I'm gonna start Mark for this one because you started the one before. I see on the labs we do have say, a neutrophilic leukocytosis, a anemia. I think it'll be important to see like what the baseline level and is this like a significant drop in the hemoglobin. Uh, Otherwise, the labs are not like that remarkable. Which is good. I think we see an elevated creatinine, which is an AKI, and I think and an elevated CK. And I think with all of this going on, I'm not sure if I would have like put this as signal or noise. It's hard to say at this point, although we do see some degree of muscle injury. And then we see a lumbar puncture, which is essentially normal, a negative crag. So I want to like comment here on what infections we would miss with these labs, and then I'll throw the mic to you, Mark. Usually, if you do a lumbar puncture and it's completely normal, the common infections you could miss are HSV. And there are many studies that show that herpes encephalitis could have an initial normal LP. And if the suspicion is high enough, you would start a acyclovir treatment until you get MRI, and then you could even consider repeat LP, especially in an immune-compromised patient. And the other thing that you do not rule out is we see that crypto antigen is negative. There is the prozone effect. You can rarely see that, where you would need to dilute the sample to actually rule out crypto. But it's less likely, but it is a option if especially if the opening pressure was actually, we don't have the opening pressure, but that's one another thing to consider. So I think that those are the things we would could still be on the table potentially, but you could look for an MRI and look for temporal enhancements, for example. And the other big thing I want to make sure that's not going on is seizure. So seizures can be non-epileptic, as you know, and with the laceration on the tongue, it has a high positive likelihood ratio for seizure. So it would be reasonable to get an EEG as well. What are you thinking, Mark?
Yeah, no, I love that analysis. Yeah. I think that, but aside from the like HSV that you mentioned, yeah, like the LP is like pretty good. Like I feel like a lot of times it's like we'll get an LP in situations and like maybe the white blood cell count is like 5 or 10, and we're like, yeah, I don't know really what to do with this. But like when it's completely normal, like I usually feel pretty good. It's ruling out what's like infectious causes, aside from the HSV caveat that Yusuf mentioned. So I was kind of surprised, honestly. Um, I'll say that, and going back to like what Yusuf was saying about seizure, I'm kind of just like stepping back and thinking about like our hyperacute like altered mental status schema that we talk about, that being like seizure, stroke, hypoglycemia, and like and drugs, right? And just making sure we kind of check those off, right? We got a CT head that didn't show a space occupying lesion. That usually really just rolls out, hemorrhagic strokes, right? We definitely can be missing ischemic stroke. So definitely would probably want an MRI and vessel imaging to further like characterize the CNS. Seizure, like Yusuf mentioned. So a lot of times patients like this in the ICU might be hooked up to continuous EEG to see if they're having non-convulsive status epilepticus. So I think that's a good idea as well. And then we have a glucose that's actually elevated. And then like I just mentioned, the UDS. So I think like the way to make progress here really is to get more dedicated brain imaging and an EEG, because maybe the brain in the MRI shows multifocal strokes, and they're like, okay, that's kind of pushing us towards like a CNS vasculitis. And if that, we'll talk about that if it gets to that. But CNS vasculitis is really hard to diagnose. And like the LP can be normal. And the CT can be normal, and sometimes patients even get like brain biopsies to like evaluate for CNS vasculitis. So it can be really tricky to diagnose. So I think the next steps for this patient for me really are MRI the brain and vessel imaging and EEG. Like you, Yusuf, I kind of just like ignored the AKI and the CK. Like if there was some blood as well in addition to protein, maybe I'd like think a little more like, is this a systemic syndrome that also has like renal involvement with the glomerulonephritis? I definitely at a minimum would just like quantify the protein. I know there was like 2+ protein, just to make sure there's not a crazy amount of proteinuria and there is like a glomerular process going on. But it's probably this patient's been sick, was found down, has a pre-renal AKI. Same thing for the CK. Like the most common cause of a CK to this degree of elevation is someone that's just been found down. And it'd be interesting just to trend maybe another CK the following day to make sure it's not going in the wrong direction. But I doubt this is evidence that this patient has a systemic like inflammatory myositis, because nothing really is fitting that right now. But yeah, I just kind of want more dedicated brain imaging for this patient.
Yeah, the other thing I was thinking is like if the creatinine is worsening or if the anemia is worsening, then I think it's reasonable to put more signal in it, like to think of TMAs, think of a smear, think of things like that. And Mark, what are you thinking about the hypothesis that this could be like medication toxicity?
Yeah, I mean, like I guess for the methotrexate, like I personally don't think of methotrexate as causing really significant CNS toxicity. Like I said, like pulmonary toxicity, hepatotoxicity, cytopenias. I don't necessarily think about it in terms of like CNS toxicity. Now, prednisone we know can cause psychosis, delirium, but for it to cause like a coma, that would definitely be uncommon. So yeah, I don't know. Is there something I'm missing, Yusuf, in terms of the medication toxicity?
No, I'm just like seeing like how high it is on your differential as we're going through this case.
Yeah. Yeah, I guess at least for the main like CNS manifestations and maybe the GI manifestations, like I mentioned before, now the prednisone could definitely increase your risk of ulcers, which can perforate and all the catastrophic GI syndromes. But everything being explained by medication toxicity, I'm not exactly sure. But like just like in real life, like sometimes like the ulcers might be methotrexate, but the GI manifestations might be something else. Like in real life, it gets a little murkier sometimes than like the CPS cases. But
Yeah, for sure.
Awesome, awesome. Yeah, that was such a great discussion. Um, this is a very challenging case, and I will say, even up to this point, we're not like involved yet. Like I haven't, our team hasn't been involved yet, and this patient is in the neurosurgical ICU. So in this next step, I know that Mark has mentioned, abdominal imaging, but we do not have any abdominal imaging for this patient. But what we do have is a CTA PE, and that was to rule out pulmonary embolism. It showed no pulmonary embolism. It showed bibasilar dependent consolidations that would be consistent with aspiration pneumonitis in the setting of her recent altered mental status and maybe a seizure. There are no effusions or lymphadenopathy on the CT. She did end up getting a MRI brain, and that showed symmetric T2 flare hyperintensities that were involving the bilateral parieto-occipital white matter. They did say that this was kind of nonspecific. It could be consistent with PRESS. It also could be consistent with the CNS vasculitis. There was no enhancement found on the MRI brain. Her EEG didn't show any seizures. It just showed diffuse slowing that was nonspecific and thought to be consistent with a toxic metabolic process. And the only other imaging here was that she also had bilateral hand x-rays. These were actually done by her rheumatologist recently, but they showed periarticular osteopenia, no signs of erosive disease or deformities, and no calcium crystals were seen. And that is the fourth aliquot.
Thank you, Jeffrey. And how many aliquots are left after this one?
There are two aliquots left.
Wow. Mark, you want to go first?
sure, yeah. I'm glad that we got some imaging. I definitely do agree with the read. It seems like of the CT, it's probably most commonly, aspiration pneumonitis given the basilar predominance. But given this patient has an undifferentiated syndrome and again had some like blood tinged sputum and like a preceding viral illness, I would definitely still do basic infectious workup to rule out, causes of community acquired pneumonia, right? And the reason I say that too is that like, could this patient have a pulmonary CNS, syndrome? I know the original syndrome started off with her being exposed to mold, right? And that just triggered, invasive molds, right? And which is common in immunosuppressed patients, right? That being like aspergillus, mucormycosis. This patient is hyperglycemic when they came in, which increases your risk for mucormycosis, and both of those conditions can invade the brain. I would say that like while maybe the CNS manifestations aren't classic for those invasive molds can also cause a CNS vasculitis. And maybe I won't talk about CNS vasculitis right now, but that kind of just the syndrome starting off with this like possible mold exposure kind of just made me think of that. But again, this is probably just like aspiration related. But yeah, like I'm glad that we got the MRI. Like I said, it's really tough to diagnose like CNS vasculitis, and I definitely would want some either a CTA or MRI to see if there's any inflammatory changes in the brain. I think another thing that can mimic also like multifocal enhancements like in the brain is also endocarditis, so that'd be something to consider as well. I don't think we're getting a strong signal for that, but yeah, that's something to consider. But I definitely probably again still want some belly imaging, and then also want some vessel imaging. But yeah, Youssef, what do you think? I have some other thoughts, but I want you to go. First.
I was just thinking that this is not necessarily like slam dunk infection. Like this is a hard case because like could there be a component of serotonin syndrome and the patient had like some seizure like activity, some increased reflexes, for example, and then they got altered in addition to other things going on. So I think that's the first part is I don't see like a strong necessarily like infectious flavor. Like it could still be like a serotonin syndrome from sertraline and a component of methotrexate toxicity causing mucositis in the mouth, for example. So that's for one. On the other hand, the MRI brain, I think, is very interesting. And could this be press? I mean, it very well could be. And the other thing I'm thinking of is I'm going to ask Jeffrey after the fourth aliquot for an ANA. Because we said before that autoimmune disease is associated with other autoimmune disease. I think at this juncture, I think it's reasonable to get like other autoimmune serologies. Like I would get an ANA as well, complement levels. And because we do see, whenever you see like anemia, kidney disease and CNS disease. I think the as Dr. House always says, it's always lupus. So this is one thing to consider as well. And as you pursue the infectious workup, I think it's reasonable to pursue autoimmune workup. And I know this patient has gotten steroids already, and we're going to treat for that. But it's one thing that I would also check for. What are you thinking, Mark?
Yeah, Yusuf, that's exactly what I was going to say. Like, I think that we definitely need to like go back to the drawing board and just probably order, basic rheumatological labs, like get that rheumatoid factor and the CCP to see the status of those, get an ANA, get some complements, and to see if like was this, the correct diagnosis all along, or maybe this patient is developing an overlap syndrome, or again, like was this, the right diagnosis? I think there is a little bit of maybe disconnect between, and I don't know if this is why Jeffrey gave us the hand x-rays, but like I typically think, and I think you mentioned this at the beginning, Yusuf, that like classically patients with like CNS vasculitis or RA vasculitis are patients with long-standing, very uncontrolled rheumatoid arthritis, and this patient doesn't even seem to have really even prominent like erosive disease like on their x-ray. So if we are considering like an RA vasculitis, which I was, there's a little bit of disconnect between maybe the articular findings and then also the CNS findings. Which I think is interesting. But I'm still wondering, it's like, is this? I assume that what's happening in the CNS right now is related to the month prior, like, because I'm just keeping in mind that this syndrome actually started a month ago. I know it kind of developed, like the reason that she came to the hospital was very hyperacute and she's comatose, she's in the ICU, she's intubated, but just kind of keeping in mind that this story does go back a month ago. But yeah, I think kind of getting updated rheumatological labs and still that CT of the abdomen pelvis could really help us make some progress here. And then, like you said too, the trends like of the labs, right? The trend of that creatinine, like you said, if that creatinine's going up, I'm definitely going to put more weight in it and consider it as part of like this syndrome. Same thing with the CK. So a couple of lab trends is CT abdomen pelvis and some of those room labs.
Yeah, and one of the things we don't see on CPS also, like, but we do in real life, is like anybody who comes in confused, hasn't been vomiting, you want to give high dose thiamine like upfront, because I have seen patients who you can develop like Wernicke's encephalopathy in like 3 weeks, like just 3 weeks of vomiting. Like, let's say she had this mucositis for a little bit and hasn't been eating for 3 weeks, you can develop Wernicke's just like that. And if it's been longer, you can develop enhancements in the brain. So in real life, I would be giving high dose thiamine in the interim, and I would also get an ammonia level, especially in immune compromised patients, as Mark knows really well. Like there are some infections that can cause it as well as medications.
I was just about to say that, Yusuf. I'm now sending arterial ammonias on ice more commonly now, especially in a comatose patient, because anemia can certainly cause a patient to be in a comatose state. So.
Wow, what an amazing discussion. I mean, still at this point, I'm still not involved yet, but you guys are just what are such a rich discussion and so comprehensive, thinking about, whether is it related to RA, whether it's an infection, if it's something completely unrelated even. And so I'm going to actually answer a lot of your questions with these next aliquot, which are the labs. These labs are actually taken by the outpatient rheumatologist when he recommended over to the local ED when she first got there, before she was transferred over to us. So he set up like a huge workup, and it's going to answer some of your questions. So from the rheumatologic workup, ANA was positive at 1 to 640. However, the ENA panel, which over here includes things like double-stranded DNA, SSA, SSB, RNP Smith, and that scleroderma SCL70 antibody, that was completely negative. RF was positive and it was really high titer. CCP was negative. Complement C3 and C4 levels were normal. ANCA was negative, and the anti-phospholipid labs, so anti-cardiolipin, anti-beta 2 glycoprotein, and a lupus anticoagulant were all negative. Then from an ID standpoint, they sent a respiratory viral panel, including COVID, and that was negative. HIV, hepatitis A, B, and C from the acute hepatitis panel were negative. Quant TB gold, syphilis, FTA antibodies, gonorrhea, chlamydia through urine, histoplasmosis urinary antigen, and whole blood EBV PCR were negative. Blood cultures were negative. Urine cultures were essentially negative. They grew, I'm just gonna say that they were negative. They grew some E. coli, but just to make this a little bit less complicated, just to say they were negative because she was asymptomatic. Other labs that were notable, they sent endocrine labs to TSH-T4, which essentially was normal. They got a random cortisol, which essentially was not convincing for adrenal insufficiency. They checked an ammonia level, which was normal. Folic acid level was really high, above the detectable level of normal. Vitamin B12 was low normal at 268, and thiamine was low at 46, with a normal being over 70. And the patient was empirically given thiamine, I believe IV for that, without any improvement. And then CSF studies that came back from the original CSF were sent for an autoimmune encephalitis panel, and it was mostly negative except for a very low titer positivity on GAD65. And that's the fifth aliquot.
Wow. And Jeffrey, the next aliquot will reveal the diagnosis.
No, the next aliquot will help you, but it will not reveal the actual diagnosis.
Okay, okay. Mark, did you have any thoughts?
Yeah, I mean, I'm glad that we got these rheumatological labs. Honestly, they're kind of what we expected, almost like this patient's baseline rheumatological labs. You can definitely have a positive ANA with rheumatoid arthritis, but the ENA panel is negative for double-stranded DNA or other kind of connective tissue diseases, and like lupus but the patient has a positive RF, which they had before, a negative CCP. Interestingly, the complements, the complements are normal, which complements are typically normal rheumatoid arthritis. But if we were being pointed in a different rheumatological direction, low complements would kind of head us in that direction. But those are negative. So yeah, most of our at least serological rheumatological labs. Not all rheumatological diseases have serological tests associated with them, so it doesn't rule out another rheumatological disease. This patient had a pretty good infectious workup as well. I guess that I'll just comment real quickly on the GAD65, because I actually had a patient with a positive GAD65 antibody within the last month. I'm forgetting some of the details. The first thing, let me back up a sec. GAD65 is the most common association is with autoimmune disease, that being like type 1 diabetes or thyroid disease. That's most common. But a lot of times we'll send it in this autoimmune encephalitis panel is because it also can be associated with stiff person syndrome. That's one of the diseases associated with. I don't think that this presentation is too consistent with stiff person syndrome, because it seems like we're not getting much spasticity or anything like that, like on exam, but something to keep in mind. And then there's also other neurological diseases that GAD65 is associated with. It's associated with like a cerebellar syndrome as well. I think it's also associated with the brainstem syndrome. And this is something I would just be plugging into Open Evidence or ChatGPT, like what are the neurological manifestations of GAD65. The other thing that I learned too is that it can be a perineoplastic antibody as well, not as commonly as some of our other like anti-Hu or anti-Yo like antibodies, but it is rarely associated with perineoplastic disease as well. But yeah, Youssef, what do you think about like the GAD65?
I also had a patient with we're working up for limbic encephalitis, and I can tell you what I learned from the review paper that I read. I'll put it in the chat at the end of the Zoom. But basically, limbic encephalitis is perineoplastic, while autoimmune/infectious is NMDA, and they treat them as like separate entities. When it's perineoplastic, it's usually associated with worse outcomes, and you have to treat the underlying malignancies. While the NMDA, which is infection related, like a patient has an infection, a virus, and then they develop an autoimmune encephalitis, is usually more responsive. And in both of these patients, the treatment is more immune suppression and looking for an underlying cancer as well. So that's the only thing I would add, Mark. Like wonderful discussion about all the syndromes associated with the GAD65. That was amazing.
Yeah. I just had some. Yeah, like autoimmune encephalitis in general is pretty hard. It's hard to diagnose unless you have some of the classic antibodies, like an NMDA receptor. And the thing is, like these antibodies take so long to come back too, so it's always a tough, judgment call whether to give this patient like immunosuppression. Because also, I think I learned that NMDA receptor encephalitis, I think like 50% of the cases also have a negative MRI. So it's just like a really tough diagnosis to make sometimes. And this definitely could, like, what do you think, you? So like this syndrome could be consistent with autoimmune encephalitis, like I guess, but it's kind of quick. It's kind of very hyperacute, I think, for those types of encephalitides, and especially specifically for like NMDA receptor encephalitis, which is not true of the other ones. Like it usually follows this like there's like a prodrome period, and then there's a lot of like neuropsychiatric symptoms. And again, that's just for NMDA receptor encephalitis. But what do you think about like kind of the time course and everything like?
Yeah, I think it's also one of those situations where you're gonna get a scan. If you see like a large mass, then you'll say, "Oh, okay, this is congruent with the syndrome." But if we don't find a mass, then we would continue ruling out all the common infections, like and things like that. And then if all the workup is negative, maybe you'll say, "Oh, this is something I didn't find out." But if we find any other signal, then we would latch onto that. So, Jeffrey, thank you for bringing this amazing case.
All right. So just to give you a little bit of a more clear time course, there was a little bit of issue, I think, initially with the patient with figuring out what the history was, because she essentially was just there by herself and there was no family for maybe like a week. So it took like for her for like a week to get transferred. And then as far if I remember correctly, essentially like we weren't really even involved until like third week, and she's been in a coma now for like 3 weeks essentially. And they only recently like discovered that she even has like rheumatoid arthritis. With this really complex patient, it's like really hard for us to know where to go afterwards. But as mentioned before with Mark, like one big thing that hasn't been done yet. That needs to be done is cross-sectional imaging of the abdomen, because she had significant amount of abdominal pain. We were worried like could she just have a small bowel obstruction? Like is there cancer there? Like is something there? So we did get a CT abdomen pelvis, and it showed there were well. Before I actually reveal what that shows, I'll mention we ordered it. And while we ordered it, we also got hematology involved just to make sure this wasn't some kind of crazy like TMA or something like that. So I'm gonna, tell you that this in a nice order. So the first thing that I'll tell you is that the peripheral blood smear that they did showed microcytosis, anistocytosis, poikilocytosis, occasional elliptocytes, and rare possible basophilic stippling. And then as part of that workup, she got urine and blood porphyrins, and they came back elevated. We also repeated her urine studies because we wanted to make sure it wasn't like a glomerulonephritis or like amyloidosis something. And her UPC came back with 2.6 grams per gram. Her UA on repeat was very similar. It was like 3 plus protein, 3 plus glucose, 2 plus ketones. Otherwise, it was similar. There was still no bleeding or no red blood cells or white blood cells. And then the CT abdomen pelvis, which is the last clue, comes back with dilated bowel loops without a notable transition point, consistent with ileus, but cannot rule out small bowel obstruction, as there's also a poorly characterized radiodense mass located in the ileum, and that is the last clue in this aliquot.
Wow. Mark, should we count to three and then say it together? I'm just kidding. Uh, I think these findings like raise this suspicion for possible lead poisoning. I think this is a very common uh, teaching point for USMLE step one. But the things that I associate with heavy metal toxicity includes the development of a neuropathy. This neuropathy can cause things like foot drop or tingling, but interestingly, it can also cause encephalopathy and seizures. It also classically causes a microcytic anemia, and like you saw with like basophilic stripling. And then in terms of etiologies of the lead. I wonder about, could this be like some sort of supplement that she's ingesting, because this could be the lead that we see in the ileum, is like the ingestion of the lead and it's still there, and it can also cause like small bowel obstructions. What are you thinking, Mark?
Yeah, I mean, I haven't thought about basophilic stippling in a while, and I think definitely the main thing we were taught was lead, toxicity, which, like you mentioned, I think that this patient has some, features for sure of lead toxicity. I would say the time for like lead usually causes symptoms over like, more subacute to chronically. Now, maybe this patient had, I heard, if I'm remembering correctly, they were in maybe an older house. The mold exposure, I'm not sure like the age of the house, but maybe they had a massive exposure to lead recently, and that's what led to some of these symptoms. But I don't know. There's something about the neurological symptoms that are just so hyperacute and so devastating that just like lead poisoning just like seems, the time course is just not sitting right with me. And there are other things that cause basophilic stippling as well. Like I think like MDS is associated with basophilic stippling, and like I think causes of like megaloblastic anemia, like classically like B12 or folate can cause some basophilic stippling. The only reason I mention that is the patient's on methotrexate, but it sounds like super therapeutic on their folate, which is good. And I would have to look up if methotrexate is associated with basophilic stippling, but I'm not really sure about that. I think other like heavy metals can be associated with basophilic stippling like as well. So I probably do a heavy metal screen as well, just like lead and like heavy metals. The other thing I just want to mention is like acute intermittent porphyria. I've sent so many porphyrin levels on patients with chronic intermittent abdominal pain and some CNS manifestations, because it is like there's so many CPSs on like acute intermittent porphyria, and unfortunately, it's always like usually a younger female that's had years and years of abdominal pain and neuropsychiatric symptoms, and it gets attributed to like IBS or like other other conditions, and then finally someone orders like a porphyrin level that's elevated. And again, like some of these features could be consistent with AIP. I would say like the arthritis maybe is just a side, because like AIP usually causes, it almost mimics lead poisoning in a way, but it's usually very like acute, like the name, acute intermittent porphyria. And like I said, lead toxicity usually subacute to chronic, but it can cause the same manifestations: constipation. Acute intermittent porphyria can cause dysautonomia as well. We're not really seeing that much here besides the tachycardia, but there's probably other reasons for the tachycardia. Can cause CNS manifestations. So I'm interested in those porphyrin levels that were slightly elevated. But it doesn't seem like this patient has like a long-standing history of these like intermittent like episodes. But again, we don't have the best history on this patient. So maybe, the husband, said that, this patient has intermittent episodes of, neuropathy, neurological symptoms, and constipation. It would fit really well. But again, like it's a very, very rare diagnosis, but, it's, possibly could be contributing to some of this patient's symptoms. What do you think, Youssef? I mean, again, I don't think it's also like could cause basophilic stippling, but again, in real life, like could just be multiple contributors to the presentations. What do you
Yeah,
think,
yeah.
Youssef?
I think the symptoms, there's a lot of overlap between the two, like lead poisoning and porphyria. Uh, and usually, like you said, it usually happens like right before puberty or right after menopause, because of the estrogen changes in the body, and that's a typical age. But even like 29 is the right age. We don't see hyponatremia. I think that's okay. Uh, I'm not. What do you think of the enhancement in the abdomen? Do you think like it would be interesting to like look at the urine and see if it changes color, like as a quick test. A lot of times in these patients, if you're considering porphyria, the test takes like a lot of time to come back, and you might like order the treatment, which is like even in the interim and start it if you're considering it, unless you can get like the lead level very quickly. And uh I haven't seen cases of lead poisoning or porphyria, but I've only like read about them a lot, like you, Mark.
Very
Yeah,
quick,
no, I think
very quickly, sorry, before you guys discuss too much, I just wanted to clarify the mass in the ileum is very bright, very radiopaque.
Yeah.
yeah.
Exactly. So I'm wondering about like we said earlier about the lead. Could this be like some sort of ingestion of some sort causing like a lead extrusion into the body? That's what I'm thinking. What are you thinking, Mark?
Yeah, totally. I think the radiopaque nature makes that more likely. If if Jeffrey didn't mention the radiopaque nature, I think like ileal disease is very interesting because a lot of immunologically active conditions like to go to the ileum because of the Peyer's patches. There's a lot of immune cells in the ileum. So the one thing that we always think of is IBD, Crohn's disease, loves the ileum. But there's other autoimmune diseases that go to the ileum too, like Behçet's likes to go to the ileum, right? And we talked about Behçet's before. Also, I had a case this year, like TB loves to go to the ileum. This patient's immunosuppressed. Histoplasmosis loves to go to the ileum. So like seronegative spondyloarthropathies have also been like rarely associated with like ileal disease. Same thing with vasculitis. So if like we rule out that this is like not lead and not like radiopaque because of the ingestion, like it, it does, the ileum is an interesting, place for disease in this patient that has like what we think is like a multi-system disease. But yeah.
Yeah, Jeffrey, please teach us.
All right, so so I'll tell you what the story was. So there was a long time where they had trouble finding the husband, and finally, when we were able to reach the husband, we realized that the reason was because the husband was hospitalized for literally the exact same thing. And so, but over there, it seems like they figured out the diagnosis faster than we did, probably because he didn't have any health problems before this happened. So what ended up happening is that essentially they had been starting to use new Chinese medicine, and they had both ingested it. Kind of, yeah, I think it was really not, clear the time course, but it seemed like they were ingesting more and more to, kind of help with the inflammation, and he was doing it with her. And so what ended up happening is that she just ingested this, I guess, powder ball, and the powder ball ended up being a bezoar that ended up in her ileum and was giving her acute on chronic, or maybe acute on subacute, really, lead poisoning. We did check blood lead levels, and they were elevated to, I believe, like 108. Arsenic, mercury, all the other heavy metals were negative. The interesting points here that, actually kind of looking back is, again, the microcytic anemia and basophilic stippling, as Youssef mentioned, and also the UA. Actually, if we look at it, it's actually very classic for a type 2 RTA or Fanconi syndrome, which is very consistent as well with lead nephropathy. Um, and the other kind of reflection I had at this point was, if she had even some maybe form of lead nephropathy and then she was given methotrexate and it was increased dose, could there have been like a little bit of toxicity from there that was obscuring things? And then she took so much folic acid that actually the methotrexate toxicity got a little bit better. And maybe that was a lot of what was complicating things in her diagnosis of RA, and then the question of, whether the rheumatologic condition was contributing it. Because over there in the other hospital, because her husband had essentially had no other, medical issues, and probably got a CT of her abdomen much faster. They were able to figure out what the source is. So this person was treated initially with a little bit of chelation for lead, and then surgical resection of the mass, which had a lot of lead in it. So this is one of my most favorite cases, and it's so complicated, and it shows how difficult it is, especially once a patient has a diagnosis of rheumatoid arthritis. Just that diagnosis of self that they have a rheumatologic condition can make the case so much more complicated, while in the end it may not be related. So yeah, I just thought this was an amazing case I wanted to share.
Wow, amazing case, Jeffrey. Complete fascinating.
Such an awesome case. Jeffrey, I think you're our only like subspecialist that hasn't presented like a case in their subspecialty, which I feel like just shows how much you love like medicine, like all of medicine, which is so awesome. This is such a cool case.
Yeah, that's so great. Steven, do you want to do the teaching points out loud? I leave it completely up to you.
Yeah, sure. Such an interesting case and wonderful discussion. And after so much wonderful teaching, I just don't have much to add. And I'll just share my favorite teaching point today. So when a person has autoimmune disease, we should always consider about the manifestations of that disease, any other associated autoimmune disease, but also about the medication toxicity or any external exposure the patient is having. So that is my favorite teaching point for today, but really enjoyed the session and thank you so much.
Thank you so much. Well, have a wonderful day, everyone.
Thanks so much.